All right, well, with that, let's go ahead and move on to today's session. I'm going to stop sharing here and just ask Dr. Anand to bring up her slides as I'm introducing her. That way we can sort of get things up and running. So it's really a privilege to have Dr. Anand here. She is the Professor of Medicine and Epidemiology at McMaster University in Hamilton, Ontario in Canada. She has been a real international leader in vascular medicine and peripheral artery disease for a long time, really contributed an immense amount to the field, just doing really pioneering work. And she's going to start off this session on stable PAD with a talk on screening, diagnosis, and risk assessment. Sonia, take it away.
Thank you very much, Deepak. It's a great pleasure to be here. And unlike you, although it's minus 25 here today in Canada, it's bright and sunny, no blizzards in sight. So wish you the best today.
Thanks.
And very happy to be here with my friends and colleagues discussing PAD, one of my favorite topics. And I'll start off today reviewing some of the considerations before we get to treatment, where Dr. Patel and Dr. Banaka will take it from there. And those considerations really focus on screening patients for PAD and determining their risk. Are they high risk or low risk? And I'll start off with a case and then return to the case at the end. So this is a typical type of patient we might see in the clinic, a 70-year-old man who is referred for risk factor modification after he suffered a STEMI. And this is his only known history of vascular disease. When you dive deeper into his personal history, he was a machine worker, retired now. He has a history of smoking that's quite substantial and stopped, as often patients do, with their STEMI, the first manifestation of vascular disease. He does not have diabetes. He has been treated for hypertension and lipid lowering. And he also has a history of prostate cancer requiring radiation and chemotherapy. And he suffers from chronic low back pain. So quite a typical history for a 70-year-old man we would see in clinic. Now, importantly, on your history taking and review of systems, you identify that he has no history of leg ulcers, no blue or black toes. And when you ask him about symptoms of claudication or rest pain, he says he doesn't walk much because of his low back pain. And so as far as you can tell, he does not have symptoms of claudication. On exam, his blood pressure is in the target range. He does not have carotid bruits, no signs of congestive heart failure, no peripheral edema. You do note he has minimal hair on his lower legs. And when you try and palpate his peripheral pulses, it's difficult to find his posterior tibials on both limbs. So the question is, should you proceed to do an ankle brachial index? Some of us have handheld Dopplers and can do an office-based ABI. Others have to refer to a vascular lab. So a moment about peripheral artery disease. Many of you will be familiar with the fact that patients with peripheral artery disease essentially have widespread atherosclerosis. And peripheral artery disease symptoms of claudication, by and large, do reflect atherosclerosis causing flow limitation in a peripheral artery. Worldwide, we're observing that the prevalence of peripheral arterial disease is increasing, now exceeding 220 million individuals affected. In the United States, this can be upwards of 12 million. And as we watch the life expectancies, certainly in high income countries around the world, increase and smoking rates plateau, not decrease, as well as with increased obesity, type 2 diabetes increasing, we anticipate that peripheral artery disease will continue to increase around the world. So it's an important vascular manifestation, patient problem that we need to have good evidence for and apply broadly to this patient population. Why is that? Because patients with PAD are high risk for major adverse cardiac events known as MACE, and you'll hear that throughout the day for sure, as well as patients with PAD, because typically this affects limb arteries, are at high risk for what we term major adverse limb event, or MACE. And those can include conditions or presentations of acute limb ischemia, sudden loss of blood flow in a peripheral artery, causing pain and extreme discomfort, tissue loss threatened, and brings patients to present at the emergency room. And another manifestation subsequent to acute limb ischemia often is the need for a major vascular amputation. So these are the types of manifestations of peripheral artery disease that we term major adverse limb event, or MAL. So if you are a community cardiologist, general internist, how do you diagnose PAD? And one of the bedrocks of our assessment of patients with PAD is the ankle brachial index, or ABI. And this is essentially a ratio of blood pressures. And we take the highest of the limb blood pressures, divide that by the highest of the arm pressures. So essentially, the proper ABI is to do 4 blood pressure readings in both arms and in both legs. And the perfect way to measure this in an office-based setting would be with a handheld Doppler. However, those are relatively expensive at 500 Canadian dollars, let's say. They're not widely available or purchased by primary care physicians or community-based cardiologists. So sometimes a suspicion or a need for ABI does require you to send your patient to a vascular lab. Now, essentially, we may think the perfect flow of blood leads us to an equal ratio in blood pressure, so an ankle brachial index of 1. And when we see that the ratio is dropping below 1, we might suspect PAD. And the typical range of normal for an ABI is 0.9 to 1.4. Any value in there we will call normal. But below 0.9, you begin to suspect flow-limiting peripheral artery disease. And as that ankle brachial index drops even lower, we can then classify patients as having moderate peripheral artery disease or severe peripheral artery disease. And when we sometimes observe higher ABI, greater than 1.4, that makes us suspect that perhaps this patient has calcification of the peripheral arteries. And this can be common in patients with type 2 diabetes. So the ABI is a simple measure of peripheral artery disease, and it also, in prospective studies, has been shown to predict the incidence of major adverse cardiovascular event. So a very simple measure that is predictive for both limb as well as global vascular risk. What about the risk factors for patients who may have PAD? And it's important to do a brief run through of these risk factors, because as they accumulate in number, so too does the probability your patient has peripheral artery disease, even when they don't have symptoms of intermittent claudication. And as you saw from our case example, sometimes you're unsure of the symptoms your patient reports because they can't mobilize very much. So let's look at the risk factors for PAD, and you can see number 1 is exposure to tobacco or cigarette smoking, and the relative risk increase of peripheral artery disease is above 4.0. It is by and large the most influential risk factor for PAD. Second is the presence of diabetes, and this also is associated with a very high relative risk increase of PAD. And I should mention, when these 2 factors are present together, the risk is not additive, 7-fold risk of peripheral artery disease. It's multiplicative. So if you have a patient who is a smoker and diabetic, your suspicion that they have peripheral artery disease should go way up. Now, what about other risk factors, conventional risk factors, as we like to refer to them as? Hypertension, dyslipidemia, or high cholesterol are also known risk factors for peripheral artery disease. And importantly, we must consider age. If you look at population-based studies in patients with PAD prevalent tract, you'll see as age increases, so too does the prevalence of PAD. So your perfect storm in terms of risk would be a patient who is older, who has multiple cardiovascular risk factors, in particular, cigarette smoking and type 2 diabetes. So with each one of these going up, if you counted them up, so too does your increase pre-test probability, if you will, that the patient has PAD. So who should be screened is a matter of much discussion, certainly when we get together to discuss PAD screening guidelines. And some of the limitations of the guidelines are the limitations of the studies that we try and synthesize together. But I think you can consider three categories of considerations when you're deciding who needs to be screened. And the first category would be risk factors. And so older age, greater than 60, plus at least one of the top risk factors, smoking or diabetes, you would be in reasonable position to do an office-based ABI. The other risk factors, as I mentioned, do confer some risks. So if you have a patient who may not be a smoker, but has multiple other cardiovascular risk factors, that may be reasonable to screen also. Now, PAD symptoms is a quite influential feature of your history that pushes you to screen or not. So PAD symptoms, we'll come to them in more detail, but essentially they're simple questions. Do you have discomfort in your legs with walking that is relieved when you rest? Very similar to a questionnaire we use in research called the Edinburgh questionnaire. And the final category that may influence you to screen for PAD is whether a patient has a history of vascular disease in another vascular bed, because that's telling you they have underlying atherosclerosis. So in the case of our patient who suffered a STEMI, that is an important consideration because as I'll show you, if you have a patient who has vascular disease in 2 or more vascular beds, they do represent the highest risk patient. So starting off with risk factors, I'll show you some recent data. And these are data from the COMPASS trial, where we're now converting the trial population into an observational cohort. And my colleague, Thomas Van Asch, essentially categorized all of the COMPASS patients into those who had risk factors and assessed whether or not they were well controlled or poorly controlled. And that would be if you had blood pressure, was it well treated with a medication versus was the measured blood pressure systolic greater than 140 or diastolic greater than 90? And what he showed is the more untreated risk factors a patient has, the greater their incidence risk of major adverse cardiovascular events. And amongst patients who have more than 4 untreated risk factors versus 1, you can see a difference in their risk is almost 5-fold by incidence. And when we look at the increased risk of MACE across these categories of patients, as well as mortality, it's at least 2-fold higher in patients with poorly or untreated risk factors. So again, this observational information shows the importance of risk factors as determinants of PAD. And if you look at it the other way, the better control we are able to achieve from a risk factor perspective, the greater we are lowering the patient's future vascular risk. Now, the second category of considerations are your patient's PAD symptoms. So asking simple questions about intermittent claudication, pain in the legs with walking relieved by rest is our usual approach. And within research studies, we often try to subcategorize that symptomatology. And if you remember from our case, I put as pertinent negatives the fact that the patient didn't have intermittent claudication, didn't have blue or black toes, and didn't have any ulceration or rest pain. And if we look at formal classifications, such as the Fontaine classification, you can see Fontaine 1 is no symptoms of PAD versus 2 that does represent intermittent claudication, can be subcategorized. 3 on the Fontaine scale represents rest pain. But usually we ask at night when you're sleeping, do you have discomfort in your legs that makes you wake up and you stand up to get rid of the discomfort? And finally, the worst category or most severe PAD reflection by history would be ischemic ulcers or the blue or black toe. So these are things you can ask in clinic and helps you again determine the severity of PAD your patient may have. And when we've looked at this in the COMPASS trial and looked at the incidence of patients based on their Fontaine classification, this demonstrates exactly the point, the green line being the patients who have intermittent claudication only, the blue line representing patients who have actually had previous peripheral revascularization, the black line representing that severe rest pain or non-healing ulcers, and the red line representing patients who had such severe PAD that they required major vascular amputation. And then if you look forward in time to say, what are their future vascular risks, you can see that as the severity of symptoms increase, or if patients come to you with a history of previous peripheral vascular revas or amputation, their risk increases for future MACE or male events. Then we think about polyvascular disease, and this is something you'll hear about throughout the morning. Patients who have a clinical vascular disease in one bed, such as coronary artery disease, peripheral artery disease, or prior stroke, when you look at their incidence risk of future major adverse cardiovascular events, it's about 6% over a 3-year period. If, however, you look at patients who may have a history of CAD and peripheral artery disease, this risk doubles. So this is an example of the power of polyvascular disease, and often you can determine this on history alone. Now, within our COMPASS trial population, we were asked the question, well, you enrolled high-risk patients who had CAD or PAD, and your trial suggested benefit for your antithrombotic combination. Should we treat all patients with that antithrombotic combination? And it would be reasonable to say yes, but we were really pushed by the community to look deeper into the COMPASS trial population to try and identify the highest risk patients. And to do this, we used 2 methods. We used data from Dr. Bott's previous REACH registry, where they had created an atherothrombotic risk score. We scored every patient using a modified REACH risk score and then divided patients into high versus lower risk. And we also used almost like a machine learning approach called classification and regression tree analysis, where we asked the computer to pick out the independent high-risk groups in our control arm of the trial. And both of these methods, we were looking at the incidence risk of MACE as well as male over a 2.5-year period. And it was comforting to see that these independent methods of assessing risk really converged on the same factors that portend risk. And you can see these include polyvascular disease, history of heart failure, low EGFR or renal insufficiency, as well as type 2 diabetes. When we looked at these factors and their presence in the COMPASS trial, more than 60% of our trial population had one of these high-risk features, And this group accounted for 75% of the outcome events in a trial. And this demonstrates if we looked at the overall COMPASS trial population, and this shows the kind of control arm being aspirin only patients, the incidence risk was 8% over 2.5 years. If we looked at patients who had at least one of those risk factors, you can see this incidence risk increases to 10. Compared to patients who didn't have any of those high risk features, the risk was lower at 4.6. So the simple assessment of the presence of polyvascular disease as well as other risk enhancing features enables us to stratify our patients as being higher versus lower risk. And higher risk patients tend to derive a greater benefit from our evidence-based therapies, such as in this case, low-dose rivaroxaban and aspirin. And you've heard the kind of adage before that you get a greater bang for your buck when you are treating patients with a higher baseline risk with a therapy that has a proven benefit in the order of 25 to 30%, your absolute risk reduction will be greater. And this demonstrates to you the classification and regression tree analysis where actually the computer independently selected out the highest risk groups. And the first division in the tree shows that a history of polyvascular disease, 2 or more vascular beds affected, they have extremely high risk of future major adverse cardiovascular and major adverse limb events. If you add to polyvascular patients other features such as renal insufficiency or heart failure history, you can see that incidence risk is upwards of 25% over a 2.5-year period. If it's polyvascular disease alone without any of those high risk features, it's upwards of 10% over 2.5 years. And other features in patients without polyvascular disease, but who have heart failure or diabetes or low EGFR renal insufficiency, they're also approaching that 10% incidence risk over 2.5 years. When we display this graphically in terms of the point I made of greater bang for your buck in a high risk patient versus a lower risk patient, you can see the absolute risk reduction here for the low dose rivaroxaban and aspirin displayed by whether or not a patient had 2 or more vascular beds affected. We have a 6% absolute risk reduction compared to those without 2 or more vascular beds affected, where the risk reduction was 1.4%. Similarly, in patients with heart failure, we have a higher absolute risk reduction in those with heart failure compared to without. Same goes for low EGFR presence versus without. Same is observed for the presence of type 2 diabetes with and without. And any single high risk feature is certainly associated with a higher incidence risk and greater absolute risk reduction, in this case, when treated with low-dose rivaroxaban and aspirin. When we think about patients who may have limb symptoms and previous coronary artery disease or stroke, and look at the incidence risk from that perspective, patients who have a previous limb high risk profile, as I demonstrated, could be past revascularization or amputation and has some of those risk factors such as renal insufficiency or diabetes, their incidence risk is the highest at 14% over 2.5 years, compared to a patient who might have no peripheral artery disease symptoms or mild claudication and no history of those risk factors such as diabetes, renal insufficiency, or heart failure. They have a much lower incidence risk. So again, simple history with a few lab tests can really help you stratify your patients into high versus lower risk. Now, let's come back to our case, because our case is intriguing. Our patient is older at 70, a very recent history of smoking, but no diabetes. We know that he has CAD by virtue of his STEMI, but no symptoms of PAD. So he would be classified as a Fontaine class 1. And according to most society guidelines, an ABI would not be recommended because he doesn't have symptoms of peripheral artery disease. I put an asterisk here because I did mention he had chronic low back pain and had extremely limited walking due to that. This is not uncommon in our patient population. So that limited walking is not really giving the stress test that may bring out claudication. So I think it would be reasonable, again, tailoring guidelines to actual patients to consider an office-based ABI. If you have a handheld Doppler, that would be quite straightforward to do. Or if it's easy for you to send him for assessment at a vascular lab, you may actually document flow-limiting peripheral artery disease, and that helps you, again, push him into the highest risk category if he has polyvascular disease. So as I wrap up, again, I do come back to this simple assessment on history. No matter if you're seeing a patient primarily for PAD, you can ask these simple questions. History of previous vascular intervention. You can see previous amputation. You ask the simple claudication history questions and those more severe claudication questions of ulceration, fluid lactose, or resting. In your patient who has CAD, you would be asking these important questions about MI, CABG, angioplasty, stents, adding to that heart failure. If you're seeing a patient primarily for stroke, you would ask questions with respect to prior stroke TIA, known carotid intervention or disease, and atrial fibrillation. And for all of these categories of patients, making sure you cover diabetes, heart failure history, and renal insufficiency. You can ask all these questions in every patient you see with vascular disease. You will be able to very simply risk stratify them as very high or lower. And I think we're going to hear next from Dr. Patel and Dr. Banaka about all the great ways that we can intervene in our patients with PAD, both medically and with interventional procedures. And from this presentation, I'd like you to take home that PAD risk factors help us predict MACE and male risk. Polyvascular patients are the highest risk group for recurrent vascular events. Limb symptoms, especially prior vascular surgery or amputation, predict future male risk. And using RCT-informed secondary prevention therapies, our so-called PAD toolkit, can lower this future vascular risk. So thank you very much. Hopefully I'm on time, Deepak, and I'll stop here.
Yes, you're perfectly on time. Thank you for that. But more importantly, thank you for a brilliant and insightful presentation as always. Let's move on now to a talk on the medical therapy of PAD by Dr. Mark Banaka. Dr. Banaka is the Director of Vascular Research and Associate Professor of Medicine at the University of Colorado School of Medicine, and really has been a dear friend for many years and a close collaborator. We worked together for many years at Brigham Women's Hospital. So Mark, if you want to go ahead and pull up your slides, we can start with that talk. And then just to let the audience know, there'll be one other PAD talk by Dr. Patel after that, really focusing on patient cases. So if you've got any questions about Dr. Anand's talk or Dr. Banaka's talk as they're giving them, please go ahead and just put them in the Q&A box. Mark?
Well, thank you, Deepak, for including me in this wonderful session, and thank you, Sonia, for a fantastic talk. And I'm going to build on some of those themes as I talk about medical therapy for peripheral artery disease. These are my disclosures, and there are several trials I'll talk about that I've been involved in, and I'll point that out as I go through this. Just in terms of definitions, you heard some of this from Sonia, and I think you're all probably familiar with PAD and CAD. Polyvascular disease, Sonia mentioned. I actually learned this term from Dr. Bott at the School of Public Health as he was looking at risk in patients from REACH and Charisma and other data sets, and that's been recapitulated many times now as a potent marker of risk. Here I'll be really speaking about CAD and PAD as a combination rather than stroke. And then we'll talk about MACE and male. And I think those terms, MACE is probably familiar to folks. Male, there are various definitions, but for the purpose of this talk, really talking about acute limb ischemia, as Sonia described, amputation or limb loss, and critical limb threatening ischemia. So I want to begin with the notion that atherosclerosis is a systemic disease. And, when I studied in vascular medicine a couple of decades ago, the notion was this is a systemic disease, which is true. But the notion that patients with these manifestations are the same or should be treated the same actually has evolved quite a bit since that time. And we've learned, for example, patients with stroke, there's a different risk benefit profile for some therapies like DAPT. And we learned that from Triton, as well as dedicated stroke trials like MATCH and PROFESS and SPS3. And the same for PAD. Although the athero is a systemic disease, the risk profile, as Sonia pointed out, and how they respond to therapies is different. And the clearest manifestation here is the limbs. What modifies outcomes in the limbs? So, some of the challenge when you see a patient with PAD in the clinic is, do you think of it, well, this is just athero, it's one size fits all, so I'm going to treat them, aspirin, statin, and I'm done, like all my athero patients on the left? Or do you get scared and say, well, wait, there's all this stuff, CLTI, and Dr. Patel will talk about the interventional considerations, and sometimes it can seem overwhelming. So we'll try to demystify that a little bit in terms of a therapeutic approach to the patient with lower extremity PAD. And I am showing this slide just to underscore that for this talk, I'm really talking about lower extremity peripheral artery disease driven by atherosclerosis. It's not always athero. Actually, in younger patients, there are other pathobiologies, but this is the dominant pathobiology, especially in patients with risk factors. And the reason I'm speaking specifically about the limbs is that we'll talk about things that impact limb vascular risk. And this is an important morbidity, as you learned from Sonia, with patients with PAD. Not only do they face heart attacks and strokes, but also limb disease. I will point out that on the right side of the slide, when we say PAD and we unify patients by nature of the ABI, actually there are different pathobiologies, and particularly in patients with end-stage renal disease, prolonged diabetes, it's not all traditional athero. There's something called medial artery calcification, which actually can lead to high ABIs and other things that may respond differently to therapies. And I think the future will be much more personalized as we think about these patients. Now, what is the sort of journey of the patient with PAD? We know about MACE risk, and we'll talk about polyvascular disease, but really it is one driven by progressive functional decline. And you can see moving from left to right, the progression of PAD may start with mild functional symptoms like claudication, then clear claudication or debilitating symptoms, progressing then to potentially critical limb threatening ischemia, and finally, really limb loss, tissue loss, acute limb ischemia, particularly in the patients who've had a revascularization. Dr. Patel will talk about that. Once you progress to need an intervention on your limbs, you are a different kind of patient, and limb risk needs to be, at the height of our preventive therapy strategy. Now, for a couple of decades, there's a lot of progression in prevention strategies for athero, and that was really driven by the top part of this slide, which were trials looking at broad athero populations at different strategies to reduce MACE risk. Few of those therapies actually were shown to reduce limb risk, and that wasn't really the point of those trials. It was to reduce MACE and to show consistency in PAD subgroups. So as we move from left to right, aspirin, followed by clopidogrel monotherapy in Capri. We'll talk about ACE inhibitors with the HOPE trial, and then statins with HPS. Those drove therapy, but there were really no clear benefits for limb outcomes, with the exception of HPS, which showed a signal for peripheral revascularizations. In the middle of the slide, there were some post-revascularization studies recognizing that thrombosis was a big problem, but really didn't show an effective strategy. The Dutch BOA trial for warfarin wasn't efficacious. There's more bleeding. Casper for DAPT versus aspirin and bypass didn't show a benefit, but there was more bleeding. And Camper was the endo trial that never recruited. And so there's really a paucity of data there. And there was one agent, cilostazol, that was approved for symptoms. So why do we use medical therapies in PAD? Well, I think the goals, as you see the patient, are: one, reduce the risk of systemic atherothrombosis, so heart attack and stroke, and they're at very high risk of that; improve function, and to reduce the risk of major adverse limb events, which is the dominant morbidity in this population who have symptomatic disease. And I do think that it's important to recognize, and as Sonia pointed out, that it's not a one size fits all, particularly when we talk about therapies that have a risk benefit profile, those that may have a safety concern like bleeding. You want to make sure you're using those therapies in patients who are going to drive the greatest benefit relative to the risk. And so there are ways to risk stratify. And I, again, learned about polyvascular disease from Professor Bott, and it's been recapitulated here in the Euclid trial on the left, which was a PAD trial, and Pegasus, which was a coronary trial, which I was involved in along with Deepak. And you can clearly see polyvascular disease patients are at higher risk of MACE, even after you adjust for everything else. And I'm going to focus on the PAD patients on the left, but it's the same for coronary patients. If you identify PAD, they're higher risk patients. And so that is one easy risk stratifier when you think about who do I need to worry about the most. We worry about all our patients, but if they're in the red bar, you should be very worried. And these are data from Sonia's trial from Compass at the PAD patients and the risk stratification based on their limb history. And she spoke about this, so I won't belabor it. But it's the patients in the bright red bar to the left that you worry about the most for limb outcomes. If they've had a revascularization, if they've had amputation, critical limb ischemia, they are forever a high limb risk patient, and you want to worry about them the most as well. So what are our pathways to modify risk in this population? Well, I'm showing you genetic data on the left from a McLaren article from Nature Medicine, very elegant article, and then some of the sort of broad pathways on the right. But if you look, there's a lot of overlap here. So lipid risk, LDL and LP(a), genetics have shown that those are risk factors. There are therapies that modify those. We have diabetes risk, inflammatory risk, smoking risk, thrombosis risk. And at the top, the most important is lifestyle. That is the starting point for all of our patients. Lifestyle interventions work. They're not as exciting as novel therapies, but they work. And on the left side of this slide, you can see several trials led by Mary McDermott, a leader in this field, and Murphy and Hyatt and others, Hirsch on the right for the Clever trial. Exercise works. It improves function. Even for patients that use arm ergometry or other forms of exercise, it is good for our PAD patients. And we can't forget that. It's hard, but it works. And we should always stress exercise, supervised exercise, which is now reimbursed in the US. It will improve function, the dominant morbidity. On the right side of the slide, smoking. Smoking is a bad actor for everyone, but really bad for patients with PAD. This is Australian data showing patients who underwent bypass surgery. And if they continued to smoke in the red line versus they were able to stop in the blue, a clear difference in survival, mortality. And there's a whole host of other bad outcomes, including reduced long-term patency in patients who continue to smoke. And there are pharmacotherapies that can help here, but we have to work to get people to stop smoking and exercise. Now, blood pressure control is an important aspect for overall MACE reduction. There's no real limb benefit for blood pressure reduction, but there are MACE benefits. And the HOPE trial showed that ramipril or ACE inhibitors were good for patients with athero. And you can see the forest plot here of the subgroups, that those with peripheral vascular disease had a really big benefit, just like everyone else. So in patients with hypertension or other indications like diabetes or renal dysfunction, we reach for ACE inhibitors first. There were a series of trials that suggested a functional benefit of ACE inhibitors. Those have not been confirmed. So I wouldn't give this with the aspect of limb benefit, but a clear MACE benefit, ACE inhibitors are preferred. I will mention here that for a while, people were worried about using beta blockers in patients with PAD, with the notion that unopposed alpha would lead to vascular constriction in the periphery and worsen claudication. That is not borne out to be true. There are a number of meta-analyses that show beta blockers are safe in patients who have coronary disease and have an indication, and so that you don't need to withhold beta blockers in your PAD patients. In terms of function, unfortunately, there hasn't been a lot of recent action here. There's a lot of studies ongoing, but really we have two tools in our PAD toolkit, pentoxifylline. That's been around for a long time, probably not very efficacious. Recent trials or more recent trials have shown similar to placebo. You could try it, it's safe, but I wouldn't expect a big benefit. Cilostazol more effective. That has been around since the late 90s, early 2000s. It does improve function. Not everyone responds. There is a GI toxicity, diarrhea, and other things that require some titration of it, and it is contraindicated in patients with heart failure. But all my patients with claudication who don't have heart failure, I give it a try, and for some, it provides great benefit. And so should be a standard approach in the patient with PAD. So when you see your patient here, exercise, diet, blood pressure control, preference for ACE inhibitors, Cilostazol were not contraindicated, address smoking risk. That's our foundation. What about lipid risk? Well, back 2 decades ago, the heart protection study did what we can no longer do, which was a placebo-controlled trial of statins in vascular disease. And you can see dramatic benefits over about 5 years for vascular outcomes. And in the red bar, the PAD patients, you'll see that in the control group, the highest risk group of patients in the entire trial, an event rate of 30% for first events at 5 years, and a dramatic benefit here of simvastatin, a modestly potent statin here, about a 6% absolute risk reduction. So very clear benefit in patients with PAD. And from that trial, there were some exploratory data looking at broad peripheral revascularization procedures and other vascular events, and there appeared to be a significant reduction. Amputation wasn't well studied, but it looks like there's also limb benefit for the statins in PAD, and several observational studies have also supported that notion. There was one randomized trial for function and PAD of statins, and this is led by Hyatt, Moeller, and Krieger. And you can see that patients who received higher intensity statins versus lower actually had a longer or greater change in their pain-free walking time. So there probably is a functional benefit of statins too. So all patients with PAD should get a statin at the very least, but maybe statins aren't enough. These are data from the Fourier trial, which added the PCSK9 inhibitor evolocumab to a statin. And you can see that being on a statin in the blue, high or moderate intensity, adding a PCSK9 moved patients with PAD down to the red bar for MACE or limb outcomes, with now at 2.5 years, another 6% reduction. So you can think of the patients in the blue as those in the heart protection study, the 6% reduction from placebo, and then you add another 6% reduction with the PCSK9 inhibitor, showing you that the combined approach is superior in patients with peripheral artery disease. What drives that benefit? Well, for limb outcomes, if you look on the left side of the slide, these are data we looked at in Fourier. There's a clear reduction in limb outcomes associated with achieved LDL down to an LDL cholesterol less than 10 milligrams per deciliter. So part of this benefit is just getting LDL lower. On the right side of the slide, these are data from Greg Schwartz and Michael Zarek showing that actually there's also an independent relationship with a subparticle called Lp(a), which is thrombogenic and a bad actor, and that's also independently associated. So it's possible that the benefits of the PCSK9 inhibitor on top of statin is both LDL and LPA. And you can see that here, the two trials sort of side by side. I know the type is small, but just look at the patterns that, polyvascular disease, big benefit for MACE risk of adding a PCSK9 to a statin. And on the bottom, you'll see limb risk and a dramatic benefit with early separation of the curves, perhaps driven as much by Lp(a) reduction as LDL reduction. So that combined strategy, efficacious in PAD. Now, these are data hot off the press from Dr. Bott, presented at the AHA for icosapent ethyl. So this is a different pathway of lipid modification beyond LDL and Lp(a), where the addition of icosapent ethyl in well-treated patients dramatically reduced MACE events and overall vascular events in both first and total. And you'll see here that the patients with PAD were higher risk and derived an even greater absolute benefit when they received icosapent ethyl on top of background therapy. So now 3 concepts here for lipid modification in our PAD patients. So I would say everyone needs dramatic LDL reduction. The European guidelines would say LDL less than 55 milligrams per deciliter. Lp(a) in the European guidelines is recommended to be checked, not there in the US guidelines yet, but you could consider that. Achieving LDL reduction, you can do that with statins, ezetimibe, PCSK9 inhibitors, and then icosapent ethyl for eligible patients additionally reduces MACE risk in this population. In terms of thrombosis, this has been a very active field, and that really has driven the notion that the broad spectrum of vascular thrombosis, and you'll hear in the next section from Jeff Barnes and Greg Piazza about venous thrombosis, these things are related. And it's not just antiplatelets, it's actually anticoagulation or coagulants that are part of the problem. And thrombin plays a core role as a bad actor, as a unifying pivot point for driving thrombosis risk. Now, antiplatelet therapy works. This was the Antithrombotic Trialist Collaborative, and you can see just like patients, high-risk patients with stroke or MI, and those with symptomatic PAD, aspirin reduces the risk of MACE by about 23%. There is an increased risk of bleeding, about a 60% risk of major bleeding with aspirin, but it is recommended in the guidelines as a class 1 indication based on these data. Now, there was a subsequent trial called Capri with clopidogrel, which showed that it was a little bit better overall than aspirin for reducing MACE, and really actually quite a bit better in PAD. And so the guidelines would say you could use aspirin or clopidogrel, and the bleeding risk between aspirin and clopidogrel was about the same. Neither of these therapies showed a benefit for limb outcomes. So this is really a MACE reduction strategy. Now, there have been attempts to look at more potent strategies in patients with PAD. Dual antiplatelet therapy hasn't shown a clear benefit in PAD-only patients. This is the CASPER trial looking at post-bypass. There was a subgroup from Charisma where there was some suggestion of benefit for MI or hospitalizations, but routine DAPT has not made it to class 1 in the guidelines because of this. I do want to differentiate patients who have an indication for DAPT with coronary disease and have comorbid PAD. And actually, those patients do benefit quite a bit. There are data from Pegasus, Themis, and other trials showing that DAPT has both limb and MACE benefit in CAD patients with comorbid PAD. But in the PAD alone patients, the data are less clear. And the same for warfarin. Although thrombosis is the problem, warfarin after bypass has not been shown to reduce graft occlusion, thrombotic events, and really has an intolerable bleeding risk with about a 3.5-fold risk of hemorrhagic stroke. Now, the notion of P2Y12 monotherapy was really cemented by the Capri trial, as I mentioned, and there was a very ambitious trial here led by Dr. Patel and others looking at ticagrelor as a more potent, less variable P2Y12 inhibitor versus clopidogrel. As you can see, there was no significant benefit of ticagrelor versus clopidogrel, although the risk reduction or the risk looks pretty similar in both arms. Ticagrelor is not labeled as monotherapy. Certainly as DAPT in patients with comorbid CAD, it could be used. And the results here look pretty similar. There wasn't a big bleeding difference between the two arms either. Nonetheless, this is not labeled for patients with PAD. Now, I want to move to thrombin. This is an older drug. It's not used much, but I'm only showing it, Vorapaxar, because it was a very targeted intervention at thrombin. And so this was the notion of just not platelets, but that thrombin is a bad actor in PAD. And Vorapaxar was a drug that's a PAR1 antagonist, which blocks thrombin action. And it was a positive trial overall. And you can see that there was a big benefit in patients with polyvascular disease on the left, and particularly for limb outcomes on the right for patients with prior revascularization, labeled here as PAD alone. And so then the question was raised, well, maybe antiplatelet therapy is not enough. And here you can see that schema I showed you earlier, the notion of blocking the platelet with aspirin on the left, but then also blocking thrombin generation. I showed you the data for Vorapaxar, which was a direct actor, but rivaroxaban as a 10A inhibitor acts proximally and blocks thrombin generation. Very low doses were studied in the Atlas trials and shown to be beneficial in acute coronary syndrome patients. So what about this dual pathway approach in patients with PAD? Well, Sonia helped to lead the COMPASS trial, and so did Dr. Bott, and this was a landmark trial, stopped early for overwhelming efficacy. And lo and behold, that combination of an antiplatelet with low-dose 10A inhibition with rivaroxaban reduced MACE, mortality, and limb outcomes. There was more ISTH major bleeding, about a 70% excess, but a very clear net benefit in the polyvascular patient, including a large subgroup of PAD. And these are data that Sonia presented at the ESC and published in the Lancet, showing that the limb benefit or the composite benefit of MACE male and amputation was consistent in all the patients, whether you had symptomatic PAD, carotid disease, and others, but there was a very clear benefit from this strategy. Building on that trial then was the question of, Well, let's look at that composite of MACE or male in patients who are at the highest risk of limb outcomes, those who've had a revascularization, and that was the Voyager PAD trial. This trial also allowed patients to be on clopidogrel in the background, and so it was rivaroxaban plus aspirin or adapt. And the primary composite was that acute limb ischemia, amputation, MI, stroke, or CV death. This was a trial that Drs. Patel and Anand led along with myself and others. And you can see the overall results here that over 2.5 years, there was a significant reduction with rivaroxaban with a very favorable number needed to treat of 39 for MACE or male. There was more bleeding, about a 40% excess of TIMI major, but a number needed to harm of 125 and a clear net benefit in this extremely high risk population. And here's the simple sort of net benefit calculator here on the left. In terms of on treatment, 181 events prevented for 1 year versus 29 caused, so a 6-to-1 benefit risk ratio of adding rivaroxaban. And then on the right side, you can see the risk benefit over time, that after patients in the red pass that bleeding stress test, there's not a lot of additional bleeding, but there's continued ischemic benefit of this therapy. And you can imagine post-revascularization that these patients, as you move from left to right, are turning into COMPASS patients, stable patients, where we have clear evidence that there's continued benefit. Now, one question is, well, what about DAPT versus rivaroxaban? They're really doing different things. I think there's reason to use DAPT in patients with PAD, particularly after endo. Doesn't mean you shouldn't use it, but DAPT does not address thrombin-mediated risk. And on the left side of the slide, you can see that in patients on DAPT, if you add riva, there's a robust absolute risk reduction, and there's not much more bleeding risk to pay. There's a clear net benefit. So just because you're using DAPT doesn't mean you should ignore thrombin-mediated risk. You may want to shorten the duration of triple therapy depending on what the need is for clopidogrel, but there's a clear benefit for inhibiting thrombin-mediated risk. So for thrombosis risk in terms of medical therapy, focusing on the PAD patient, aspirin, antiplatelet monotherapy if they're high bleeding risk, but for patients with polyvascular disease, high limb risk, and acceptable bleeding risk, aspirin rivaroxaban has the best data to support its use in the PAD patients. All right, what about diabetes risk? You know, we have limited time here. I'll say that the traditional notions of lowering A1C, you know, foot hygiene, all of those things remain critical in patients with diabetes. We don't want to ignore that. It's unclear that A1C reducing alone reduces MACE risk, but they are important for things like retinopathy, kidney disease, and even foot ulceration. Then the question is, are there other diabetes therapies that provide greater benefit? Well, one class of drugs are the GLP-1 agonists, and liraglutide is one of those agents shown here. That is a drug that in patients with diabetes doesn't just reduce A1C, but it reduces MACE and mortality, even greater benefit in PAD patients. And there's actually an amputation benefit for liraglutide published here in 2018. So this is an agent that you should prefer in PAD patients if possible because of the MACE risk, limb risk, in addition to A1C lowering. And there are potentially functional benefits of this class that are being explored now. This is a trial called STRIDE with semaglutide, and we can see if that will also lead to an improvement in function. Now, one class of drugs that is sort of the next statin is the SGLT2 inhibitors, and there was some confusion around PAD because one trial showed a risk of amputation in patients with PAD with SGLT2 inhibitor with canagliflozin versus placebo. And you can see those data here. This was very scary for many of us that treat PAD patients. My take on all of the data now, we've had a ton of data for SGLT2 inhibitors, is that these are really good drugs for patients with diabetes, vascular disease, particularly with heart failure. And you know, there are dramatic benefits for heart failure reduction, kidney complications, and MACE risk. We don't want to deny our patients that risk. There's only been an amputation risk really clear in one study. The others have not confirmed that. And I think that if you were going to have any pause, maybe the patient in the hospital with critical limb ischemia at high risk for amputation, you might wait to start the SGLT2. But otherwise, in my patients with PAD and an indication for SGLT2 inhibition, I don't hesitate to use it. There are broad and dramatic benefits of this class. And I think we shouldn't deny our PAD patients this access of therapy. So for diabetes risk, A1C, foot hygiene, and then preference for GLP-1 agonists, SGLT2 inhibitors in patients with an indication. I will comment on inflammatory risk. We don't have any tools in our toolkit here. There are studies for IL-6 inhibition, which hold promise, and there are data that anti-inflammatory therapies reduce MACE risk. Hopefully, the future will have something that we can reach for in our toolkit. Right now, we don't. So this is a busy slide. You'll have this, but I think as I break down my therapies for patients, lifestyle, blood pressure lowering, LDL lowering, consider icosapent ethyl in those eligible, and antiplatelet monotherapy, all patients. The high risk MACE patients, so with diabetes, think about a GLP-1, SGLT2 in those that have indications. For polyvascular patients or those with high male limb risk, aspirin and rivaroxaban, if they have an indication for aspirin and ticagrelor, like prior MI or diabetes or coronary disease from Themis, I think that aspirin and ticagrelor is very reasonable to do. In terms of limb risk, you can see those listed here, and I spoke about those. And really the only thing we have for function at this point is cilostazol and perhaps statins. I think one of the issues, though, is, how do you tailor for each patient? Sonia went over some of this, but this is sort of a simple table that you might take home, and sort of this is my personal approach to it. But, I think on the left side, my patients with PAD, no matter what, lifestyle, antithrombotic therapy, lipid lowering, I do check Lp(a), and I try to get LDL less than 55, ACE inhibitors if hypertension, and then, very intensive care of their diabetes. For the polyvascular patient, or the patient who's had a revascularization, amputation, or CLTI, they're really at extreme risk. And the difference there is I really think they need to be on more than antiplatelet monotherapy. Unless they're at high bleeding risk, I would consider adding rivaroxaban or another more potent antithrombotic strategy. There is a bleeding risk, but I think in these patients, the benefit far outweighs it, perhaps in the yellow too, but you want to personalize that for your patients. So I'll pause there, say thank you, and look forward to the discussion and Dr. Patel's presentation. Thank you.
Well, that was truly masterful, Mark. I mean, it was just a really great review of a lot of important data and excellent perspective on how to implement those data. And there are a number of questions already coming in, but I think it probably makes sense to move into the patient cases, and I'll bring in those questions as they come up. So let's get Dr. Patel on next to queue up his cases and slides. But while he's doing that, let me just introduce Dr. Patel. I'm sure everyone in the audience already knows who he is, but he's the chief of cardiology at Duke University. And beyond that is a professor of medicine there and a noted clinical trialist and researcher. I've had the great pleasure of working with Dr. Patel for several years. He's been a leader in many areas, including in the field of PAD, and he's prepared some patient cases for us to discuss here. And again, to the audience, I would say go ahead and type in any questions you have, or even just thoughts you have about the cases. And those questions or thoughts will be coming to me, and I'll field them and pass them on to the panel.
Thanks, Deepak, and hopefully you guys can hear me well. And like Sonia and you and others, we're in North Carolina dealing with 2 inches of snow, which is frozen everything we can do. So we appreciate you all joining. Hopefully everyone appreciates that. What wonderful 2 talks we just heard. Sonia really with a powerful talk on how we can think about our patients in clinic, and then Mark just going through a wealth of data about revascularization. So I'm going to, and PAD and just all of the management of our patients with vascular disease. So I'm going to talk about trying to incorporate these into 3 cases. I think over 20, 30 minutes, it's a bit of an interventional perspective because each of the cases does get an intervention. I'll sort of ruin the surprise up front, but we'll sort of talk about what are the things that we should be thinking about for those patients, what therapy should we be going through, and how do we go about it? So these are my disclosures that you've already seen. I'll start with the first patient. We've talked a lot about PAD, but I thought we would just start with a patient that does speak to some of those issues. Our patients are often complicated. I call this case, is this peripheral artery disease? A 69-year-old woman who actually was sent to us to get a left heart catheterization for a non-ST elevation MI, and she has prior smoking, as we've heard, hypertension, hyperlipidemia. She has a normal ventricular function, came in with classic cardiovascular symptoms in this day and age with high sensitivity troponin, was pretty quickly identified to have non-ST elevation MI with those symptoms, actually has moderate MR. And I'm going to show you the angiograms. As you can see, before I even play the angiograms, somebody has thought that she's had heart failure. At least she came in with some, even the normal left ventricular ejection fraction, she's had some shortness of breath, and she has at least an IJ Swan-Ganz catheter, again, due to some shortness of breath and heart failure management, and then has this angiogram. So there's the right coronary. It's calcified before we inject it with the radial JR4 there, you can see, but it's occluded. I'm going to move, hopefully these are playing for you all, into the left system. Again, you see a very complex calcified left system. Both, you can see my sort of cursor here, the circumflex is occluded, the LAD's coming down and providing collaterals back to that occluded right. I'll show you one more picture here. And just a, obviously a complex coronary disease that's probably been going on for quite some time, because you can see this very robust collateral to the chronically occluded right coronary, aneurysmal LAD near the diagonals, and an occluded circumflex. So it doesn't, we have all these battles about intervention and what we should be doing, but this isn't a case that's very complex, at least if the patient can undergo bypass surgery, most people would say, with her presentation for a non-ST elevation MI. In our institution, thinking a little bit about timing with antiplatelet therapy, there's some other issues. She's got moderate mitral regurgitation and had some heart failure, so doing that mitral valve at the same time. We're right radial, as you can see in this case. We're radial. You don't know that we're right radial, but we often talk in our cath lab about making choices about access. So I'm going to see if I can go to the next slide. So here is the next slide, and everything seems straightforward until we try to evaluate the patient's lima, and they've already thrown up an ARS question for you, so we'll have you answer that in a second. But you can see that the lima is patent, but the subclavian has significant stenosis. And behold, when we check and say, what was her blood pressure in her left arm? It is 60 millimeters lower than the right arm, and one of those things we should probably make sure we know about before we get access points. Either way, here's the question. For this patient, do you recommend bypass surgery with vein grafts only, multivessel PCI, CABG after left subclavian stent, CABG MVR after left subclavian stent using the lima, medical management? Enter your answers now, if you can. So choose your answer and enter those. See how many people are getting it. And then we have some answers here. Most of you said CABG MVR after left subclavian stenting. Some people thought multivessel PCI and mid-cab after the stent. I do think we opted for what the majority of you all thought about, and we'll talk about some of the therapies in this patient who, even on this angiogram, has significant calcification. For doing a CABG MVR after the left subclavian stent, I'll just show you some of that now as we went to that. Let's see if I can. Lots of moving pictures here. So, for our interventionists in the audience, we take a carefully. I tell our fellows we take a 90 centimeter catheter and try to get very carefully to the subclavian, or 65, and then have a wire that crosses it. Remember that the subclavian stent sounds easy. It's pretty calcified. The key goals in the subclavian stent and getting the REO imaging is to make sure that this patient, as you see, has a little bit of vertebral stenosis in the lima, and that if you're going to do the intervention, you have to find views in which you're going to do the intervention and preserve the lima and the vertebral without crossing it with your stenting. And so as we did this, we were thinking, we want to be sure we do that. And so I'll see if I can move us to the next picture here. You can see that we're now going across and ballooning it. And there's a little bit of a dissection with ballooning it. Before we stent it, we make sure that there's space between where we're going to stent and where the patient's lima is. You have to get good images there. Not to belabor it too much, but you can see that we do a balloon expandable stent. One of the things we do in the periphery here, at least in the subclavian and aortoosseal diseases, is we're often using a high caliber, at least radial strength stent to keep that vessel open. And then as I show you this angiogram at the end, you'll see that thankfully, it looks like the pressure gradient's much better. We can actually measure it. The lima and the vertebral artery are okay. It's a generally not very complicated procedure to do, but worth having everyone on board to say that's what we're going to do. So that's case number one that I suspect we're going to have some conversation about, think about. But really what I wanted you to think about in the decision-making, one was what should we do, but then also, is this polyvascular disease? You know, Deepak has in many ways added so much to the cardiovascular literature. One of the first with REACH registry and other key observations was around the increased risk of patients with atherosclerosis in multiple beds. I've shown you a patient who's got multivessel coronary artery disease. She presented with a non-ST elevation MI and then was found to have a left subclavian stenosis. So that's in itself one of the vessels that's not directly around the heart. Is that, how do we think about that? Is her long-term CAD, PAD risk higher? And what would we treat her with? And I asked that to the group because I think there's going to be some conversation as we go forward about how do we care for these patients? What are some of the questions that people have around that? I found this case to be interesting because there was at least some controversy in our own practice about both the type of revascularization, the timing of potentially doing that. And we think a lot about the lower extremities. We're going to get to the next two cases, which are lower extremities patients. But there are patients, unfortunately, that have a variety of atherosclerosis, both in their carotids, their subclavians, abdominal viscera, aorta, obviously aorta iliac. Additionally, as Sonia highlighted, and some of you know, in the COMPASS trial that Deepak and Sonia were involved in, patients with carotid disease, at least head and neck vessel disease might have been involved. And so subclavian disease in itself, it gives us another view into that. All right, well, maybe a little bit more of a direct case that to think about. A 76-year-old woman with life-limiting claudication. I'll just take a moment to talk about that. You know, before I show you the angiograms, is this in our practice? It's pretty similar to what Dr. Banaka has highlighted. You know, we would see these patients across a variety of spectra. You know, she, like a lot of patients, unfortunately, in our area and with PAD, had prior tobacco use history, had hypertension, hyperlipidemia, and unfortunately in the past had coronary artery disease with PCI, but also had at least had some disease in one of the superficial femoral arteries, and then had atorvastatin and cilostazol tried BID for this, and had at least been advised to take walking programs. We've been doing remote walking and trying some of those things in the COVID era, and her ABI was 0.62 with no palpable femoral pulse. And ultrasound showing possible acute occluded iliac. And so the first sort of steps you had heard first from Sonia and from Mark were to see the patient in clinic, obviously risk stratify them, do the exam, see if you can get them on evidence-based therapy to reduce their risk for a variety of issues, including cardiovascular events, improve their function. And then if those things don't work, still try to do interventions potentially to improve their function if it's limiting her. This isn't a woman with an ulcer. She's 76 though, and has reasonably normal renal function. So I'll show you sort of the idea that we thought, well, we would consider revascularization. As you can see, she's also had back surgery that I didn't talk about, because on the angiogram, you can see a metal plate obscuring some of that right external iliac going into the aorta, but you can see that the left iliac is 100% occluded. And in fact, some of the views of the rest of the tree looks okay with some of the interventions that had been done. And so I'm going to go back to see if I can advance us. Sometimes that requires stopping these videos. I apologize. So that is her iliac. And so from the interventional perspective, this is not extremely complicated, but it is 100% iliac occlusion. And so for us in the lab, we would think again about how do we do that, try to avoid having our fellows and faculty image their hands, but sometimes because we're trying to exactly understand where we're getting into the vessel, we will demonstrate well in the fluorosave that we are able to get the wire into that occluded vessel with the bright tip catheter up to where we think we have flow all the way here. And then we have an occlusion, and this is a short iliac occlusion with a catheter below. And then we spend some time trying to get the wire from above or below across the occlusion. And you'll see a second here where we'll spend some time, and then it thankfully pops across. And then it turns into, for the most part, work on trying to connect those two vessels. And so I'll spend a moment just showing you some of that. So you can see that this is a patient with significant peripheral vascular disease in that iliac occlusion. We are able from the left side then to put up a wire and put a balloon up. And after the balloon is placed, actually deploy a stent that you can see here. Again, I think because it was very near the common iliac, this is a balloon expandable stent, although some people would also at times use self-expanding stents. Again, a pretty common intervention in the aortoiliac position. And some would say, well, Manesh, there's been some randomized trial data, of course, in revascularization of PAD in claudicants in the aortoiliac position that showed maybe a little bit of symptom benefit, certainly not as much questions about long-term benefits. And I think as you've seen already from Mark and others, when you do revascularization, these patients have high risk. So we've done the revascularization procedure on the patient. You heard a lot about different therapies, one about the Voyager trial, one about Caglor and the Euclid trial. I guess in your practice today, I would ask, you've done this or you see this patient in clinic, how would you treat this patient? Please place your best single choice, aspirin plus clopidogrel post-revascularization for life-limiting claudication. Rivaroxaban, 2.5 BID plus aspirin or clopidogrel 75 milligrams. Go ahead and enter your answer now. And take just a minute to do that to make sure you get some time to do that. Okay, let's see if we have enough responses, what people did. Still about 20% saying aspirin, clopidogrel, 80% saying Riva plus aspirin. Nobody opting just for aspirin, nobody opting just for clopidogrel. I think that's fair. And I think that the thing that we've learned from, and I'll show a few of those slides in a bit, the thing that we've learned from Voyager PAD is substantial risk to our patients that we do these interventions on. You know, despite what many had said, and I even remember when we were doing the Euclid trial, I had conversations with sort of the late great Will Hyatt about, you know, PAD, and certainly patients with ABIs are at risk. But the moment we do revascularization, their risk is changing, just like the coronary patient. There's something about that symptomatic patient that we tend to do revascularization on. Additionally, obviously, when we do revascularization, we are, of course, taking an inflammatory atherothrombotic patient and putting devices into their system that themselves may lead to thrombotic events. I think this is one of the sort of take-home slides from some of Mark's great presentations. Dr. Banaka, Dr. Anand, and myself, we were all, amongst others, on the Voyager PAD trial. And those are patients, 6,500 or so patients with lower extremity peripheral vascular disease who got either surgical or endovascular revascularization. And the comparison of adding rivaroxaban on top of background therapy of aspirin, and clopidogrel was allowed in either arm, you can see that acute limb ischemia, there's a total reduction in efficacy endpoints, and it's driven by those limb events that Mark mentioned, 110 less acute limb ischemia events, 20 or so less major amputations, some less reduction in MI and stroke, and numerically some less cardiovascular death. So all of that balanced against not an increase in intracranial hemorrhage or fatal bleeding, but an increase in some of the ISTH or TIMI major bleeding issues. So you can see that there are some trade-offs, but the lion's share of the limb and cardiovascular benefits seem to be pretty bound towards helping these patients who get lower extremity revascularization. All right, well, for maybe the last 10 minutes here, I'm going to go through a last case and then some wrap-up comments, and then hopefully we'll have sort of robust conversation about the great data we've seen, our sort of perceptions of that, and then potentially also these cases. Third case, I think I've potentially shown some of you all, I'm not sure if you've seen this, has been for a few years, been taking care of this patient who's thankfully beyond 90 now. 90-year-old woman from rural North Carolina with hypertension, really very functional. And she reported that she had hit her foot on the screen door when she was walking out to get her dog. This is, when I say rural though, it's only about 45, 50 minutes from our institution. And so the local primary care doctor and the team had tried to wrap the ulcer on her foot for about 2 months, sort of on the anterior lateral aspect. And then she was seen a month ago by a local surgeon and was referred to our wound clinic. There was consideration that if it didn't heal, there'd be some concern about some tissue loss. In our wound clinic, her ABI was 0.42 and ultrasounds were performed, again, looking at her lower extremity in a non-invasive way with that ABI just to say, what do we think the anatomy is? And that showed a distal occlusion of her superficial femoral artery into her popliteal, and I'll show that in a second. At 90, she couldn't remember, maybe she smoked in her youth, but she did not really have a huge smoking history, was not a diabetic, obviously had significantly advanced age, was pretty mobile, even with it being 90, even though I didn't show you her creatinine, which was around 1, that didn't put her EGFR anywhere near normal. She's not a very large lady. At 90 was only about 120 pounds or so. And so I'll show you some pictures here in a second, but gives you a sense of this patient. You've already heard about the ABI and the role it plays. I would just highlight again that it's fundamentally important in our risk stratification of all of our patients. And I'll show you in a second some of the long-term outcomes of patients from John Dormandy and others that initially presented how these patients do with outcomes. And just for those of you who are taking care of some of these patients at home, I find that the vascular ultrasound in clinic can be very helpful because as we see either a very tight lesion or occlusion, we start to see decrement of that waveform or monophasic or loss of that waveform. We have started, and some of you have seen this done in our interventional room with thinner patients. We can put a catheter up and do a multi-angle 1 injection view to save some of the contrast. And so pretty quickly we can clear her abdominal aortoiliac system on both sides with an angiogram from reasonably higher up above. And then when we do the single leg shots, you can see that in fact she had an occlusion, which we were lucky enough to get across, perform atherectomy and ballooning and some stenting, and then behind the knee trying to just balloon to get flow back to her lower extremity. I think part of what I would say for our peripheral limb ischemia patients, this is a data from Dr. Cricky, who conducted a study to evaluate the mortality rate from all cardiovascular disease and cardiovascular health patients in patients with large vessel PAD. They screened 565 or so patients, and 67 patients or 11% with PAD were identified by non-invasive testing. And then they just followed the patients. These patients were then followed prospectively for 10 years. It's not a large number of patients, but this was published in 1992 in the New England Journal. But what the results were really dramatic about were that, you had normal subjects over 10 to 12 years. That's the sort of, mortality rates. The patients with asymptomatic lower extremity or large vessel PAD, symptomatic large vessel PAD, and then severe symptomatic large vessel PAD had up to 50 to 75% mortality at 10 years. Now, some of this is obviously driven by age and other comorbidities, but I don't think we think of peripheral vascular disease, and even though these data are older, we've seen some recapitulation of that in Voyager and others. And we talk a lot about cancer, we talk a lot about heart failure, but bad peripheral atherosclerotic disease and its 5 and 10-year mortality is still pretty significant, especially obviously when you have wounds. Obviously, the patient I just presented is 90 years old, so she's already outperformed a lot of the curves, but still with meaningful life and limb. I put the same question up, but I added one now. Critical limb ischemia, do you change how you take care of your patients? Do you add warfarin? It's not a surgical bypass, but I'd be interested in what some of you all think here, and then I'll I'll make a few comments about whether we add clopidogrel in revascularization, whether we add warfarin, what's our thoughts? A similar question, different case. Don't know if it changes your thoughts. We did add warfarin. There are existing data, as Sonia and others could speak to that. Okay, we'll see what people have voted for again here. A few people for warfarin, a few people for aspirin and clopidogrel, still about 75% for Riva. So we, plus aspirin. So we discussed the 6,500 patients or so in the Voyager trial design. I do think this is probably our most contemporary data to tell us how in those patients where we have to do peripheral revascularization, what that event outcome rate looks like. 2.5 milligrams of Riva twice daily compared to placebo. And again, the primary efficacy endpoint of MACE plus male, as you've seen, are sort of major cardiovascular events, and then TIMI major bleeding. Here's the KM curve that I know Dr. Banaka has showed and others have seen. Just highlight for everyone that this KM curve is notable for the fact that in the placebo group, out to a little beyond 3 years, 20% of patients had one of these events, acute limb ischemia, major cardiovascular events, including MI, ischemic stroke, cardiovascular death. This is 1 in 5 of your patients you do a revascularization procedure on, and then that's a significant reduction to 17.3%, but at 6 months it's 1.5%, so pretty early reduction, and number needed to potentially treat of 65. 1 year that goes, and it just, as you can imagine, continues on. I would say at 3 years, sorry, I'll just go back to make sure you saw that. At 3 years, it's 2.6%, and the number needed to treat is 39. A lot of people ask about clopidogrel use, and this is data that Will Hyatt has published, and this is clopidogrel use with or without, and again, you can see that the rates are interesting to me with clopidogrel. People say, well, why is the overall event rate lower with clopidogrel than without clopidogrel? And that's because with clopidogrel are probably endovascular patients majority versus surgical patients that are higher risk, but there's no p-value for interaction. The hazard ratio is the same. So you can add it if you want to, but we should recognize that the primary therapy is critical. I'll just end with a couple of messages about what you've already heard, which I showed you 3 peripheral revascularization cases, one of the subclavian, one of what I'll call the aoroiliac, and then one of the SFA popliteal and coronary related bypass, intermittent claudication, and then critical limb ischemia. But really, don't forget to manage all the risk factors, whether they're getting a revascularization procedure or not. Initially in circulation, Sumit Subrawal from our institution, others in Danish registry showed that the likelihood of getting evidence-based therapy, if you had PAD, just the statin, for example, compared to having coronary artery disease, was 50%. And then colleague Jeff Berger and others looked at outpatient practice across the United States, and this is published in JACC. And red bar is PAD plus CAD, polyvascular. Blue bar is PAD only. First unfortunate thing is, even with polyvascular disease, the use of a statin was only 50 to 60%. And that was 30% in patients with PAD alone. And although smoking cessation is discussed a lot with PAD, CAD, less so with PAD alone. So again, your likelihood and your opportunity from any antiplatelet therapy, exercise activity, lipid lowering therapy, and then lifestyle potential improving therapy like Solostazol, lots of opportunities, and not really a significant, what I'll say, there's still a big gap in getting to evidence-based therapies across the country. Even if this data is a few years old, I don't think it's moved dramatically. This is data that Shrek Vemlupalli has shown from our group and others that now 6 years later, but I would say that we've seen recent data that hasn't moved the needle huge, that up to 30% of patients who had an amputation in the United States did not have any form of arterial testing prior to the amputation, whether it's an ankle brachial index, invasive angiography, duplex ultrasound, MRI, or CT. So unfortunately, my 90-year-old patient thankfully got to see a surgeon and got to see some people, but if you don't get to the right people, you have unfortunately a high risk of losing your limb. And we've seen national maps of these disparities, and it's an opportunity for both improving our outcomes, but improving health equity. So I'll just conclude by saying, we've seen that not in every case is more anti-platelet therapy better for chronic disease. We do have to be selective about that. Post-PAD revascularization has some limited data with DAPT. I've talked about the antithrombotic low dose for post-revascularization, the symptom choice and making sure that you have both lipid-lowering therapy, you've done blood pressure control, you've tried to get the patient to be as active as possible is critical. So with that, I'll take questions and stop sharing my slides, and thank you all for listening.
Well, those were really 3 great presentations, lots of wonderful content, and I appreciate all 3 of you sticking to time. So we've actually got 30 minutes here as was planned for the Q&A and the discussion. And Manesh, I'll start with you while our other 2 panelists just come back on camera. There are a lot of great questions that I want to open up for discussion. This one's just about your case, so it's just directly to you. The person is commenting that current ACC guidelines do not recommend MVR for moderate MR. So do you have any comments about that case? I mean, here it was in conjunction with CABG, but did you have any?
Yeah, I think that's the thing. It's I'm not sure exactly if I get the question right, but if you have moderate to severe, but if you have moderate MR at the time of coronary artery bypass surgery, there's some feeling you should do MVR at that time. If it's just for moderate MR by itself, then obviously I don't think that's the case. And it's a judgment call, right? It depends on how much you think it's a coronary revascularization versus that. The other things in that patient that I highlighted is that she did have heart failure, and even with that swan, and had some evidence of probably some functional mitral regurgitation that was leading to heart failure. The two things we've seen in the last year, in fact, I would say, I think the field is going towards at least bypass surgery and valves, is nothing good comes from waiting, right? So I'll just say that if your patient with bypass surgery and has moderate MR, what we've seen is that if you wait, you might have, again, recurrent heart failure. If you decide to do the mitral and they have tricuspid disease, we saw a randomized trial from the CT Surgical Network that said doing tricuspid repair at that same time, or ring at least, there was a trade-off between more pacemakers, but we saw functionally at least better ventricular function at 1 year. We're going to find out at 5 years how that translates into patient outcomes. So I do think we're answering those questions. There is also a CT Surgical Network study of CABG plus minus MVR at the time from moderate to severe that showed, again, some symptomatic benefit.
Yeah, and I'm glad the question was asked. And I think most cardiac surgeons actually, when doing CABG in that type of patient, would have also addressed the mitral valve at the same time, same if there was moderate aortic stenosis as well, for that matter. Here's another question that's very specific. What is your thought now about using, I'm really glad this question was asked, using a low dose of apixaban instead of rivaroxaban? And maybe Mark will just have you handle that one. I think, and then maybe we can all just discuss the dosing a bit, because I know some people must have looked at Compass, Voyager, 2.5 rivaroxaban. They're aware of the 2.5 of apixaban. And just to complete the question here, it says, so why not use low-dose apixaban instead of rivaroxaban? After the analysis of the Annals of Internal Medicine, with rivaroxaban is less effective in preventing VTE and causing more intracranial and GI bleed. So there are a lot of different things that have really been raised in that question. One has to do with equivalency of dosing between rivaroxaban and apixaban, indications. So there's a lot to unpack there, actually. It's a really good question. But Mark, maybe we can just start with you in terms of dosing, and is it okay to use apixaban 2.5 instead of rivaroxaban 2.5? Of course, the answer is no, but perhaps you can expand on why the answer is no.
Yeah, no, thank you for the opportunity. It's a great question, because it is sort of alphabet soup out there with different DOACs and doses and indications now, because we use them for so many things. I guess I'll start with Sonia's comment in her presentation that you should guide by well-done RCTs when you think about what you use and which patient at what dose. And you know, the Atlas trials for rivaroxaban surprised everyone, and there was a huge phase 2 program to try to understand what dose of 10A inhibition would be efficacious and safe in patients with vascular disease, arterial disease. And this was, you know, like a 2,000 or 3,000 patient study, which said lower is better. In fact, 2.5 milligrams twice a day of rivaroxaban was better than 5 milligrams twice a day. I know that's counterintuitive, but really the question is how you modulate this combination of antiplatelet and anticoagulant. And that data then was brought forward into the Atlas pivotal trial, to Compass and Voyager. And that's about 25% of the total daily dose that's used for therapeutic anticoagulation for atrial fibrillation, for example. Now, for apixaban, there's a really, I think, you know, there's a perception it's a very safe drug. And I think a lot of the data in the individual trials show that. But when you think of apixaban at 5 milligrams twice a day, that was studied in the Appraise trial. And because it was a full dose, actually, lo and behold, it didn't work for ischemic benefit, but it was stopped early for harm, for bleeding risk. And I think that is a cautionary tale that as we extrapolate, you know, between these trials, we really should focus on the within trial comparisons. And, you know, if you were even to guess at what the right dose of apixaban would be for a vascular dose, it'd probably be around 1 milligram, right? But we don't know that. We have no prospective data to show it. I would say 2.5 milligrams is much too high of a dose to be using in a vascular patient on top of antiplatelet therapy. And so I think I would very much stick to the labels, and the only DOAC that's really has has efficacy and safety data in vascular diseases, rivaroxaban.
I agree with you. I mean, this is definitely one of the cases where you can't just speak about classes if you're speaking about the COMPASS or Voyager indications for anticoagulation. There, it really has to be 2.5 BID of rivaroxaban. Now, for VTE, AFib, you know, there one can have a discussion. There's great data for all the NOACs, in fact, but when we're talking COMPASS Voyager, it really is drug specific. Any additional thoughts, Sonia, you want to add on that point of NOAC choice in general?
No, I agree with Mark 100%. We have two large trials, COMPASS and Voyager. We've meta-analyzed them. We see extremely consistent effects with the dual pathway inhibition 2.5 BID Riva plus aspirin. So, I mean, strong evidence, not even much debate there. And so if you have it available, that should be the first choice for certain in PAD. And also there are other indications, CAD, polyvascular disease. So, you know, that's certainly important. In the future, if there's a trial with a comparable dual pathway inhibition with, say, a PIX 1.25 BID, then, you know, we'll look at it. But for now, Riva 2.5 BID plus aspirin is what we use in PAD. And I just would highlight that when we first had our COMPASS results, before the drug was even approved and available, we did have some pharmacists call in and say they've already started to use the DOAC combination with aspirin, and turns out that they had used apixaban 2.5 BID thinking they're equivalent. Now, this wasn't widespread, but it did highlight a potential for a medication error, you know, on behalf of, you know, multiple people in the healthcare system. So I always like to emphasize to the patient, take this drug as prescribed. If anyone wants to substitute, you know, give us a call. And the more CMEs we do, I think now people recognize Riva 2.5 aspirin is what we use in PAD.
And those are great points. And I don't know if it's necessarily the case in Canada, but in the US, a lot of times when we write for a prescription, it gets substituted at the pharmacy because of issues of what's on the plan, with, you know, issues of cost, et cetera. And with the NOACs in particular, I think that can be really confusing because there are a bunch of NOACs, different doses of different NOACs, different doses for different indications, some with adjustments for kidney function or weight. So I think, Mark, what you said is really good advice. Just always check the label because it can otherwise be hard to keep it all straight in one's head. You know, Manesh,
I was going to make just one comment, if you don't mind, about that.
Yes.
Yeah, maybe the coffee's kicking in, but that question really got me fired up because I like the two things about that question, which was really critical. One is it's really a great question because they're saying, well, look, you know, we know that these things work, so why not think about it one or the other? So really, really important to recognize that the vascular dose for PAD, CAD is a much lower dose than apixa. And so that 2.5 milligrams of Riva was studied here for this population. But one could argue, let's be clear about each indication and when you should use them. So, you know, what I tell people is if you have vascular disease and AFib, you should be using an AFib dose. If you're treating PE or VTE, then you should be using that dose. If those two indications don't exist and patients have vascular disease, then traditionally you would use that vascular dose. Obviously, there's questions around any individual patient. I just want to make sure we knew that. The second is this, I think, again, we've all participated in the trials, but I think the observational analyses, both in Annals and JAMA that are out in Medscapes, I've seen the, you know, sort of comparison of what's the observational data for Riva and or apixa in patients with AFib or VTE, and how does that translate into my thinking about therapies. I just want to be really, really cautious. Those are not randomized comparisons. There's a lot of limitations on the dose used. For example, in AFib, you know, 2.5 milligrams of apixaban was only studied in Aristotle in less than 500 patients. And so, but in the observational things we see, it's used in about 25% of our population. So even the 2.5 milligram dose of apixaban is maybe not as well studied and maybe getting used off label in our practice. And so if we see a lower bleeding rate, I just want to be very cautious about what people might be interpreting.
Oh, good. I mean, in fact, I was going to get your opinion since you were involved with leading Rocket, just what your thoughts were for AFib. I know this session wasn't about AFib, but we're going to talk, we talked a little bit about AFib yesterday from a sort of post-ACS antithrombotic therapy perspective, and later today from an electrophysiologic perspective. But I would be interested in your thoughts about agent of choice in AFib, given the randomized clinical trials and now these non-randomized data that you pointed out, and other factors as well. Pixaban's twice a day, rivaroxaban's once a day.
Yeah, that's
But
great. I wish I could. I probably, it's probably because I have PTSD from having these conversations so many years about this. But let me just say that the single greatest question I get, and I think the biggest misconception in the field, is that twice a day dosing is better for bleeding and once a day dosing isn't. I just want to be very specific about that one issue. I'm not going to talk about rivaroxaban. I'm not even actually going to talk about apixaban. I'm going to talk about the only agent where they did at least a reasonably sized study to see twice versus once daily dosing, which was edoxaban. And our colleagues with edoxaban in phase 2, in about 1,200 patients, and I think Jeff Weitz and Stuart Conley and others, took 60 milligrams of edoxaban once daily, 30 milligrams twice daily, and then tested that along with 30 milligrams once daily, and actually took a dose ranging study in atrial fibrillation patients. And what they found was that the 60 milligram once daily dose had a higher peak and a lower trough than the 30 twice a day, which makes sense. And the bleeding rates were lower with the 60 milligram once daily, and that the trough was probably driving that. I just want to say that again. The once daily dose of a NOAC in the same population of patients had less bleeding, and this isn't a Pix or Riva. That's how the investigators for edoxaban went forward with the once daily dosing. So what I find unique is that we then have an observational analysis in Medicare where people get it started on one drug and then a different drug, and in fact actually have a lower event rate with one of the agents, but then we adjust to have a higher event rate and we say one agent's better than the other. So just be very careful about observational analyses. I think it's very important to just think about the risk of the patient. Do they look like the trial that I'm going to use or think about, and be specific about it? I do think all of these work. I just am cautious to think that one's dramatically better than any other. I think you have to be very cautious about that.
Yeah, no, I think those were really great questions. Oh, please, Sonia. Yes.
I mean, there's great data from large trials in AFib, and in our own institution, for example, we ran the RELY trial with dabigatran, right? Clearly beneficial, for which there is a reversal agent. Good data supporting a PIX5 BID and Riva 20. So we always say treat to the AFib in our vascular patients. So we know we're going from a low 1/4 dose of a DOAC to a full dose. And then within that, what are the considerations? And there's so many factors to consider. There's the patient's comorbid factor, their renal function, their bleeding risk. So it's not a simple answer. I find within our own institution where we have Stuart Conley, Sam Schulman, Jeff Weitz, John Eichelboom, myself, we really, our thrombo nurses are sometimes dizzying, like last week we used this DOAC for a similar type of patient. This week you're saying that. I think what we're seeing is first guidance is, do we have a large randomized trial to back us up? Second point is we tailor that to the therapy to the patient and their comorbid factors, their past history of bleeding, their adherence to once daily versus twice daily, many factors to be considered. So the art of the DOAC is, choosing the randomized trial, informed DOAC, and tailoring it to the patient.
I think that's really good. Any comment about warfarin, given your pivotal role in WAVE? Some people did vote for warfarin in the poll.
Yeah, I think that's really important to raise. So the WAVE trial, warfarin antiplatelet vascular evaluation in patients with peripheral artery disease, they were randomized to warfarin antiplatelet versus antiplatelet only. The patient population was very similar to PAD and COMPASS, so an outpatient stable PAD. And as many of you know, we did not observe a MACE reduction with the warfarin plus antiplatelet compared to antiplatelet alone. And unfortunately, we did observe a 3.5-fold excess in life-threatening bleeds. So these were intracranial hemorrhage or bleeds causing death. So the WAVE trial really put the brakes on the use of warfarin together with antiplatelet therapy in outpatient PAD patients. There are some circumstances where we might choose to use warfarin in combination with antiplatelets, but it's usually short term. And, those could be in a complicated post-ALI situation where we're worried with a single conduit below the knee. There's certain circumstances where we say, yes, we'll transition from IV heparin aspirin to warfarin aspirin, but short term. We'll reevaluate this patient in 3 and 6 months and take it from that point. So I'm very, very cautious about warfarin together with antiplatelets based on the WAVE trial.
Yep. No, that's really, it was really a very insightful trial and a terrific answer. There's still, so let's see, is coming, what's this, a comment, RCT result is coming December 2023. Not sure what trial he, she was referring to. I'm not sure I understand that question. Did one of you mention a trial that's coming out in December 2023? Okay, not sure what that meant. There's still some questions about the antithrombotic dosing. Why is there a difference? And this is with respect to CAD versus PAD. Well, I don't know that there is a difference versus CAD versus PAD. So just to answer the questioner here, for CAD and PAD, we're really talking about COMPASS data, and the dose we're talking about is 2.5 BID, and the drug we're talking about is rivaroxaban. Where there's a different dosing, a higher degree of anticoagulation is for atrial fibrillation, where in general we would use a full dose of a NOAC, adjusting for renal function and or weight as appropriate per the drug in the label. And for DVT and PE, that's the sort of full dosing. But where we're talking about reduced dose of anticoagulation, specifically with rivaroxaban 2.5 BID, along with low dose aspirin, is in that CAD or PAD patient, if that wasn't clear. All right, and there are a number of other questions here as well having to do with targets for LDL and PAD. So maybe we can just go around the room, so to speak, and see what people say. Mark, you were the one that brought up the issue of LDL, and for that matter, even triglycerides. So what should the target for LDL be?
Well, thank you, Deepak. I mean, it's this is a target that's always moving, because we have more and more evidence from our randomized trials. The current US guidelines say, 70 milligrams per deciliter, below that for high-risk patients, including with PAD and risk factors. The European guidelines, endorse a lower target based on IMPROVE IT and 4A and Odyssey of 55 milligrams per deciliter, and also talk about LP(a). I'll say my approach is that LDL is a toxin. It's sort of like radiation. I mean, you want to sort of avoid any exposure. And so then the question becomes, how do you get your patient as low as possible? There's no lower limit for safety. I wouldn't say 70 is a good place for somebody to be if they could be at 50 or 30. And so you want them below that and below 55. And so my approach is I don't dose adjust statins anymore. I use the most potent statin at the highest dose for patients like this, because there's no reason not to. There's no safety issue. I do use ezetimibe and PCSK9 inhibitors, and I try to get my patients as low as possible. And I'm particularly happy if they're below 55 and as close to 30 as possible. But maybe others have other views on that.
That's a very clear answer. Yes, please, Mash.
I was just going to say, so listen, from the biologic and the way I treat my patients, I agree with Mark, because I do believe there is no what I'll call floor to what you can do to help your patients, right? It's a lifetime of atherosclerosis and atherothrombosis risk. And we spent a lot of time talking about the thrombotic side, but we should think a little bit about the athero side and then the inflammatory side if those things are coming, if we think about the disease process. So I agree with the concept, and I try to get my patients on as statins as high doses they'll let me, depending on what they're reading and what they're hearing. My sense is, if we're thinking about the evidence, and this is where I am a little bit interested, I think the evidence is going to show this, but if we're thinking about the evidence to date, all of our PAD data is subgroups from large outcome athero trials. And I want to encourage our colleagues in industry that are thinking about ways that we can think about showing a difference. I say that because not only do we believe that, but there aren't randomized large PAD event reduction trials in PAD populations. And I say that again because my thinking, at least as an interventionist from that platelet world, changed when we did a large PAD only population study and said, turns out when you have a PAD only population study, 30% have coronary disease. But a lot only have PAD, and those, at least in the thrombotic side, didn't benefit dramatically from more antiplatelet therapy. Now we've learned about that. It seems highly unlikely that that's going to be true for LDL lowering. Don't get me wrong. So I would get it pretty low. But what we know in clinical practice right now is 30, 40, 50% of people with PAD only aren't getting even a statin sometimes, depending on the practice place you're in. So we need to get them on statins first, and then we need to think about how to get them as low as possible. And we probably need to be thinking about strategies and trials to get them really low to show that the limbs don't have as many events, because I think that limb event is going to drive that function, at least in my mind.
Mark, do you have a comment on that? I see your hand up.
Yeah,
I see
no,
Mark's hand up. I have a comment too, but go ahead, Mark. Yeah.
go ahead, Sonia, go ahead.
No, I was just going to add on the point, Manesh, you said about we need trials in PAD. We certainly do, because the WAVE trial, for example, we extrapolated from CAD that warfarin and aspirin in WARS 1, 2, aspect 1, 2 looked really good. We did a meta-analysis. We said we anticipate a 35% risk reduction. So let's test it in our highest risk patients, PAD. Lo and behold, we couldn't predict the safety outcomes. They were different than the CAD population. So I agree with you wholeheartedly that we sometimes can't just extrapolate from CAD trials to our PAD patients. In lipid lowering, we've done that by and large, although Mark has done some great work with the PCSK9 inhibitors. It seems really convincing that the lower we go with the LDL, the lower our male risk will be. But I do support you in that. And I'll just add one other point around inflammation. I think we should see trials in that area. We're starting a pilot study looking at colchicine in patients with PAD, the LEADER PAD trial. So hopefully there'll be more, cheap, simple to take, minimal side effects in PAD patients. Mark.
Yeah, well, I'm just going to agree with both of you and say, it was a privilege to work with Inforia, and the Odyssey team has done a great job, but those are secondary and exploratory endpoints. There's no lipid modifying agent with a label to reduce limb outcomes. And think about that. I mean, we've been talking for, an hour and a half about how important they are. We have rivaroxaban, first drug to have an indication for reducing limb outcomes. But I think, there's an important translation and implementation part of this. And so that it can't just be the exploration, in the subgroup anymore. I think really to move the needle in this population, we need to have those dedicated studies. And Sonia, to your point, prove the hypothesis. I think the other part I'll just say is get on a statin first. Manesh, you said, and I totally agree with that, but I still see patients coming in on like Simva 20 or pravastatin and stuff like that. And I just don't really, I understand when the drugs were developed, the tolerability profile was unclear, but why, if you're going to use a statin, you're not going to use sort of the biggest and best that you can get. That I think would be even a small change. You're going to take a pill. Why not take Rasuva 20 instead of Simva 20? You still get a better LDL reduction.
Great. There are a few other questions here, and we've got just 10 minutes. So this is someone commenting about the COBRA RCT result, December 2023, comparison of bleeding risk between rivaroxaban and apixaban for the treatment of acute VTE. So I must say, I hadn't actually heard that trial before. I don't know, did one of you mention that? I didn't hear it, but at any rate, that's interesting that such a trial is going on. So I was unaware of it, but look forward to the results. Maybe.
Yeah. Yeah, Deepak, that's noted in the editorial for some of these, the two observational studies I said, and there are some smaller ones. And again, I look forward to randomized trials of the agents in the same population. I want to be very specific about that. I also want to be very specific about the fact that we want to be very specific about the dose and the indication. So why do we need the antithrombotic different doses? The full dose, 5 milligrams of apixaban, was studied in ACS on top of dual antiplatelet therapy and stopped for ICH increase in APPRAISE-2. So obviously that dose of a NOAC was too much. As I anticipate, if you did an ACS study with 20 milligrams of rivaroxaban, that's why we did 2.5, and the Atlas investigators did 5 and stuff. So there has to be some dose thought to the indication risk. So that's number one. Number two, the VTE data, remember there's some of the VTE trials that some of the NOACs didn't meet their endpoints. So we want to be specific about that too. So yes, I look forward to randomized trials. We want to get our individual patients, and we have to make decisions. So I'm not suggesting you shouldn't be using any of these. You should be using all of them. Just use the dose that's been studied in the patient. That's a key step. And so I'll state that. And then the only other comment, just because Deepak's got such a live group here about statins and other things, I totally agree with what you said, Mark. The problem in PAD is people come in with their legs hurting. You try to increase their statin. They read everywhere that it causes muscle aches. They're not sure they want to increase their statin. And so I think part of the deal of just getting people with PAD on a statin and getting these trials done is to convince people that that leg pain is maybe the vascular disease and not the statin. We'd love to blame the drug and not the athero, if you will.
Well, that's what I was just saying, 20 of Rasuva and 20 of Simva, it's the same dose, but you get a little bit more LDL, anyways.
No, absolutely. Those are good
Yeah.
points. Sonia, there's a question. I want to make sure we get it in. We have only 8 minutes left. It pertains to something you're talking. The question is, why not do ABI on everyone with significant risk factors? And you did touch upon some of the issues and guidelines and so forth, but why not do it? I think the implication here is that it's cheap, it provides incremental value. Why not just do it is what the question is.
Yeah, I think that the challenge is the feasibility of doing it. So that even if you're in your clinic doing your ABI with a handheld Doppler, it still adds 15 minutes to your time. So if you had a vascular nurse with you who's doing it routinely and you've got that covered somehow, then it could be reasonable to do it as you add up age and smoking, diabetes. But the challenge is, at least in Canada, it takes time. Few clinics have the Doppler and the reimbursement is pretty low. So in Canada, if you try and bill for an office-based ABI, you get $12. So a lot of them are like, yeah, it's not worth it. So I think that's a feasibility issue. The second thing is referring patients to vascular labs. That's really contextually dependent. So some tertiary care centers or large urban centers, that can be very easy. In smaller centers, it's not as easy. So there have been screening studies, the Partners program, many of us will remember, where we've tried to look at observational data to say what's highest yield. And again, the 3 factors that come up as being, highest yield to direct you to do an ABI, apart from symptoms of intermittent claudication, would be age, advancing age, diabetes, and smoking. So if you have those older age diabetes and smoking, I think it's reasonable to do. I think from a feasibility perspective, saying do it in everyone, it wouldn't work, and it would be lower yield in those younger patients without risk factors. I also have my hand up, Deepak, just to make a big plug for when we talk about future trials or interventions. We have excellent RCT evidence for PAD patients, and we keep saying there's a PAD gap. Our patients are underdiagnosed often, and certainly undertreated. So a big plug for implementation science research. It could be a randomized trial and maybe some other design, but we really need to move from the great evidence we've generated to getting it to patients. And I think we need creative researchers thinking outside the box to tackle some of the system level issues, hospital issues, as well as physicians and patients. So we're moving towards that type of thinking, a design thinking approach to solve our local problems. And I think I'd urge everybody to think that way.
Yeah, it's a really great point. Mark, I see you have your hand up and we've still got about 5 minutes.
Yeah, just real quick, the question on ABI, I agree with everything Sonia said. I also think there was a historical concern that people would use ABI to find patients to do interventions on, and that, might lead to an increase in inappropriate interventions. And I think that, I personally don't agree with that. I mean, I don't think that identifying disease will necessarily lead to inappropriate interventions, but there's all these other great interventions. And that really aligns with what Sonia said about implementation. If you don't know they have the disease, how do you intervene from a medical therapy perspective, counseling, supervised exercise? And so I personally have a very low bar to do ABIs. I know that there are, task force guidelines and other things. I'm not advocating to disagree with those, but I'll say my personal practice is to know people have the disease. Patients deserve to be educated and informed about their risk factors, so you can have shared decision making about all of the great non-invasive interventions that we have to offer.
Yeah,
I mean,
perfect point.
Yeah,
Yes,
I was just gonna say, as an interventionist, I'll channel my inner Josh Beckman here and just say that I think the task force is wrong, right? The reason I say that is it's a political thing, unfortunately. You know, if I got up and said there was a screening test for cancer and you could have a therapy, most people wouldn't say, hey, we're not going to put that into practice. Unfortunately, this is a screening test for elderly patients with vascular disease in their limbs. And there's truly a health equity issue here where we're saying, well, we're not going to pay for a $25 ABI because now we actually have therapies that might reduce their limb events. So I just put the slightly controversial point out there and say we're applying different screening tests and data and evidence to different populations based on the population that is being affected. One could argue, until recently, you could have argued if you had an abnormal ABI, you got to do all this stuff you're talking about anyway. But now there are going to start to be some therapies that are different for people with lower ABIs. And so that conversation is a little bit different. It's not just athero prevention.
I'm not sure that what you said would be controversial amongst us. I think we probably all agree with you, but I think you're right. More broadly, that would be viewed as controversial. I really like your analogy. If it were cancer screening, you know, no one would be making that argument for what is actually a pretty easy, cheap, quite useful test. But Sonia hit it on the head. She mentioned Canada, but it's true in the US as well. I mean, in general, practice doesn't shift if there's an adequate reimbursement for the time spent doing something. It's been a real rate limiting step. Well, we've only got a couple of minutes here, and then the next crew is going to come up to talk about complex thrombus management. So I just want to take this opportunity to thank all three of you for really brilliant presentations, and I thought a very informative discussion. I certainly learned a lot from all three of you and everything you said. I'm sure our audience did as well. So thanks so much for joining in this session.